So my patient is 60-year-old lady, resident of Begusarai, Patna, homemaker by occupation, and presented with chief complaints of swelling in left breast for 1 year and ulcer or swelling 9 months ago. So this history part I should present without seeing them, everything.
Yeah.
Okay. So history of present illness. My patient was apparently.
You can scroll it for us, just but you try to not see and present.
Okay. So my patient was apparently asymptomatic 1 year before. Then she noticed a swelling in breast while taking bath, and it was insidious in onset and was initially of around 3 into 2 centimeter, and then gradually progressed as told by the patient by the hand gestures, and there was no aggravating or relieving factors to the swelling, and after 3 months the patient developed an ulcer over the swelling, which was having tendency to bleed on touch, and for which she consulted local physician at the primary health care center, and from where she was referred to our hospital. And in our hospital, the workup and the treatment started. After that, the patient told the swelling decrease in size, and the ulcer also healed. So the ulcer lasted for around 1.5 months. There is no history of trauma to chest, and there is no history of any other lump or swelling in the opposite or same breast and axilla, and there is no history of any nipple discharge, and there is no history of any radiation exposure in the childhood as well, and there is no history suggestive of any systemic metastasis or distant metastasis. Past history: patient is having no significant no medical history of regarding diabetes, tuberculosis, COPD, asthma, thyroid disorder, epilepsy, etc. She gave history of receiving drugs for her disease at our hospital only, and from the history it was suggestive of chemotherapy, which lasted around for 7 to 8 months. No history of any surgery in past, and there is no history of any cancer or cancer-related death in family of the patient. Personal history: patient is vegetarian by diet, normal bowel and bladder habits, sleep pattern unaltered, and there is no history of any addiction to any use of tobacco or alcohol, etc. Then menstrual history: patient got menarche at 14 years, menopause at 52 years, cycles were mostly regular, and she had 5 children, and all were live birth by normal vaginal delivery, and eldest child is female, 24 years, and youngest is male of 12 years. Age at first pregnancy was 16 years, and for every child she on an average breastfed for 1 to 1.5 years, and there is no history of HRT. So summarize my history: 60-year-old postmenopausal lady with the complaint of left breast swelling for 1 year with ulceration, no history suggestive of distant mets, past medical history suggestive of chemotherapy, which led to healing of ulcer and decrease in size of the swelling.
So there are few corrections, okay? So first thing is, there is some terminology, okay? So what is a lump, what is a swelling, what is a mass, okay? Yes. So you are supposed to use that terminology in that particular organ only. It's a swelling in thyroid or neck somewhere. It's a lump in the breast. It's a mass abdomen, okay? So lump, so do you know the definitions of what is a lump? What is the difference between lump and swelling?
Like swelling is any visible protuberance, ma'am. And lump is more of finding of palpation, so I avoided it.
Lump usually with the primary disease, surrounding organs or surrounding structures come to form a lump.
What is difference between lump and swelling?
So swelling, that I know, ma'am. Any visible protuberance is swelling.
No, it's not.
Okay.
So any swelling which is well defined, if it is well defined, like what is a swelling is something that is well defined, but anything that is vaguely felt by the patient, okay, is referred to as lump, because most of the neck swellings are well defined. Like they will have definite, see, this much is the swelling. They can tell that it's not approximate, this much is this swelling and this has grown. So anything that is well defined and distinct is referred to as swelling. Okay, anything that is vaguely felt and cannot be easily characterized but noticed by patient, so they can just tell the approximate size and increase of the lump, size of the lesion, that is known as lump. Okay.
Okay.
So anything in abdomen is a mass. Okay. So this one, what's an ulcer?
Ulcer is any breach in the epithelium or mucosa.
You can modify it. Anyone?
Break in the continuity of the surface.
With associated.
Break in continuity of epithelium. Yeah.
With associated inflammation.
With exposure of underlying tissues.
Either it can be or it is with or without necrosis. Okay. So any breach in continuity of the epithelium. Okay. Then so in your breast case, you are supposed to refer it as lump. Okay. Thyroid case, it's a swelling. We'll tell swelling in front of neck. Okay.
Okay.
More so on the left side, more so on the right side. That's how thyroid swelling is there. Any thing that is felt in abdomen is a mass. Okay.
Okay.
In soft tissue sarcomas and all, it is swelling. Okay. So that is noted by patient. These are standard things that you should use. So see, she's a postmenopausal. See, first thing you can tell it in a refined way. See, in breast case, no, sometimes you'll not have time. Okay, they will tell, just summarize your history. So your history should include everything, but in a refined way. Okay, so you can just start as a 60 years postmenopausal lady. Okay, does this homemaker has got any significance or not?
There is like not much occupation related risk factors are there, so maybe.
So nothing. It's just significance that sometimes if they're it's not significant, you should, if she's educated or not. Okay. So who is educated might come to you little early stage. It's not necessary, but that is the only significance that you can point out. Okay. So you can start your history saying 60 years postmenopausal lady presented with complaints of noticing lump in the, you can tell it here only, painless lump in the left breast of 1 year duration with an overlying ulcer for the past 9 months. Okay, like that you can put it.
Okay, ma'am.
Go to the next page.
Yes.
Okay. So incidentally noted while taking bath. Okay.
Yes.
So what is insidious? What does insidious mean?
The patient was not much aware of the exact time of origin of the swelling. It might be some slow growing, or like she was not aware of the exact time of starting of the lump.
So you already told it was incidental while taking bath, and it is growing gradually.
Yes.
Okay. So either you tell that or you tell it was insidious in origin. So both are not required. And whenever you are telling size of swelling, it's good that you put dimensions, but you should tell approximate, okay? Because she will not be able to. It was approximately of the size of 3 cross 2 centimeters, gradually progressed to attain the present size approximately 5 cross 4 centimeters, or you can just tell it has doubled in size.
Okay.
To double the size. What will be the aggravating and relieving factors in a lump of breast lump?
Relieving might be if there is some.
No, is it painless or painful swelling?
It is painless.
Then there are no aggravating relieving factors that are for any abdominal mass. Okay.
Okay.
और any swelling in the neck that is deglutition के साथ कुछ हो रहा है, ऐसे कुछ है, पर breast lump के लिए aggravating relieving factors नहीं होते. Okay.
But if he is a premenopausal patient and in the reproductive age group, we can consider as a fibroadenosis or fibroadenoma.
Yeah, but
Aggravating
he's
relieving factor.
telling it is painless. Okay. If he says it is painful, then he can tell it's aggravated with so and so and relieved with so and so. Okay, it's a painless swelling. Okay. So, yeah. So it has gradually progressed in size, and over the time duration, it has developed an ulcer. Okay.
Yes.
So, yeah. So whenever you describe ulcer, what all you should describe with relation to history. So
ulcer and discharge.
So first you complete swelling. What all you will describe regarding swelling?
In history, ma'am? In history, swelling first mode of detection, then history of growth, like rate of growth, size, and associated with pain or not.
And so here only comes your any other swellings noted in this ipsilateral breast, opposite breast, or bilateral armpit. You can as well refer to as axilla. Many of the examiners will accept axilla. Okay, so armpit or axilla you can tell. Okay, so or anywhere in the body. So that will be more relevant when you tell regarding swelling. So what is that site, size, growth, shape, okay, and rate of growth, and any other overlying ulceration you can tell. So regarding ulcer, you can describe later, okay, once you complete the swelling, right?
Okay.
Right. So this swelling was gradually progressive and was non-responsive to the conservative measures, after which he has seek medical attention for the definitive diagnosis. Okay.
Yes, sir.
And received chemotherapy. So there only you can see there are two ways of presenting this case. This is a post-NACT case. So
yes,
you can tell already a diagnosed case of breast cancer. She was evaluated for the present complaint and was diagnosed with breast cancer, and for which she received chemotherapy. And then you can tell about the progression. Okay. So that way is one way of presenting. One way is like you tell whole story and then tell that she received chemotherapy. Either way is okay, as long as the opposite person understands what you're telling. Okay. So for ulcer, what all you'll ask?
Ulcer, ma'am, site of ulcer, then time of onset, then discharge from the ulcer.
Whether it is progression or regression.
Yes.
Okay.
Yes.
Pain, well, painless.
And pain.
Okay.
Yes.
Yes. Then discharge you told.
Yeah. Yes. Then we can also like in the examination we can see it is dependent or non-dependent part, like that also.
Not necessarily.
Okay.
Any other ulcerations? Okay. Is it the same or any other ulcerations and response to the treatment? Okay, in your case. Okay. So when you are telling only about the swelling, you can tell there was no history of any trauma. Okay, because you are telling about ulceration, it was incidentally noted without any no history of any trauma and gradually progressive swelling with development of ulceration over the site of the swelling for the past 9 months, which was progressive in spite of conservative measures for which she consulted a oncology center and was diagnosed with breast cancer and started on treatment. Okay.
Okay.
Yeah. Next.
So then most of these things are covered already.
Yeah. So why are you asking about fever?
Fever to rule out any inflammatory cause. So this is a proven case, maybe due to
suppose you don't you before your diagnosis of before your history of receiving chemotherapy. Okay. So your differential diagnosis can be still tuberculosis. Can it be?
Yes, ma'am.
It can be tuberculosis. So multiple discharging sinuses might be. These can be differential diagnosis. Okay.
Yes.
So so as I told, this noticing no similar lump. Okay, there will not be any similar lumps. Then there is history of noticing any other lump in the same breast or opposite breast, bilateral axillary region, or anywhere else in the body. So that way you complete it.
Okay.
Nipple discharge will come along with the description of the swelling. Okay. So swelling of the arm, you asked?
Yes, ma'am.
For what?
Swelling of arm, like maybe there is bulky nodal disease, so it can lead to arm edema, like that.
Okay. So lymphedema. Yeah. Yes. Okay. Previous breast biopsies other than for this lump. Okay. So that you can tell in past history. Okay. Previous breast biopsies. So in this present history only you can tell there was a core biopsy done from the on evaluation for this lump, and for which has proven it to be malignant, and then she was started on treatment. That's it. So what is nipple discharge? Characteristic nipple discharge. What all you'll ask in nipple discharge?
So in nipple discharge, ma'am, I will ask or examine, for asking point of.
Yeah. Suppose patient present with nipple discharge. What are all the points you are asking for? So
first, color of the discharge, amount, and
first, whether it is spontaneous or only pressing. Okay. Yes. Next.
Spontaneous or then color and amount, and examination we can see it is single duct or multiple ducts.
Okay. And whether it is causing any discomfort, staining, or what is the nature of discharge, as you told. So can you tell me a few differential diagnosis for serous discharge? Okay. Greenish discharge and bloody discharge.
So serous discharge.
One second.
Duct spontaneous serous discharge from the single duct can be ductectasia and malignancy as well. And bloody discharge from the single duct spontaneous, mostly it can be intraductal papilloma or it can be malignancy as well. And greenish discharge mostly is associated with ductectasia only.
Okay. So and milk?
Galactosile. Okay.
So either it can be galactosile or it can be prolactinomas.
Yeah.
Okay.
Yes, ma'am.
So spontaneous, serous, single duct, 3S. You have to remember. Okay.
Yes, ma'am.
Point more towards malignancy. Yes. Okay. It can be bloody, but
ऐसे लिखा है कि serous discharge, fibrocystic disease और ductectasia and CA, और उसमें भी सिंगल डक्ट और मोर देन वन डक्ट में फाइब्रोसिस्टिक, ये 3 DD दिया है.
Yeah, spontaneous, serous, single duct. That is triad. Okay. Most often they'll present with serous discharge, but sometimes we see blood discharge in CS. Okay. So papillomas are also one differential diagnosis for bloody discharge. Okay. So that's about nipple discharge. Okay. Yeah. Why are you asking about previous breast biopsies?
So previous breast biopsies, we can know about any prior benign disease, as benign disease with proliferation with or without atypia is also a risk factor for CA breast.
Okay. So what are you worried about? Suppose I say, what are you more concerned to know in previous breast biopsies? Like what is the diagnosis that you are more interested in?
Like LCIS or atypical ductal hyperplasia.
There's no LCIS now. Okay.
Yes, ma'am.
So it has been removed, right? So it's no more a term that you should use. DCIS, yes. Okay. Then
atypical ductal hyperplasia, atypical
Correct.
lobular hyperplasia, flat epithelial atypia, and radial scar.
So suppose I give you sclerosing adenosis.
Yes, ma'am.
Risk factor, not risk factor.
It is a risk factor, ma'am. It is proliferative benign disease without atypia.
Florid hyperplasia.
Florid is not a risk factor.
With atypical hyperplasia with few ductal components.
It is a risk factor.
Okay. Do you know the relative risk of all this?
Yes, ma'am.
Yeah.
So with atypia, it will be more than 5 for most of the lesions. Like in David given like relative risk in a table, relative risk more than 4. In that table,
so what is it for atypia with ductal cell seen, or what is it for DCIS, and what is it for sclerosing adenosis, florid hyperplasia? What is it?
For sclerosing adenosis, it is around relative risk is around 2, ma'am. And for ductal atypia, it is more than 5. That like I have remembered like that only. And for DCIS, LCIS, it is around 8 to 10.
More or less, okay. But it is less than 2 to 4, more than 4, okay. And 7 to 10 times. That is what you told us. 10 times is for DCIS, okay. And for with atypical ductal cells, that is 7, okay. And with sclerosing adenosis and all, it is less than 2. If you find a patient with sclerosing adenosis, what you want to do?
So first I will try a stereotactic biopsy, and if it comes as radial scar, then excisional biopsy is indicated.
मेरे sclerosing adenosis करके frozen section में आया. What you want to do?
Okay. So in frozen section, if it is sclerosing adenosis, I will see margins. If margins are clear and there is no in situ or like component of cancer, then
there is nothing except sclerosing adenosis. Pathologist has given you. So what you want to do? You want to do wide local excision, you want to do address the lymph nodes, anything else you want to do, or you just want to stop it?
If margins are clear, I will not do anything.
Sclerosing adenosis kaha margins, what margins are for? Either invasive or in situ carcinomas. Sclerosing adenosis is nowhere related to this too, no? So there will be patchy areas of sclerosing adenosis. This is what they'll give you.
So in
you need not do anything. Okay, you need not do anything. Okay?
So ma'am,
okay? So yeah, now you tell me what we discussed postmenopausal lady.
Yes.
So what has the age got to do with the breast cancer?
So age, like if it is basically it is related to exposure to estrogen. So if the patient is having early menarche and late menopause, there will be more duration for exposure, estrogenic exposure, leading to more chances of developing CA breast. So
okay. It's all about
Age more
increased
than
estrogen exposure. What is early menarche? What age of menarche? In Indian scenario, you can tell. Okay. So, what is usual age of menarche? What is usual age of menopause? What is early menarche? What is late menopause?
so early menarche is less than 12 years, ma'am. Usual age around 13 to 14 years, and menopause age is in Indian scenario it is 55 years. I'm not remembering it exactly.
Anyone else?
According to
Anyone else?
definition, menopause age is more than 60 years. But when to call it late menopause?
No, we will talk about definition of menopause, but what is the usual age of menarche and menopause?
50 to 55 in Indian scenario.
50 to 54 Indian scenario.
So I think
What is
menarche is
about
11.
what is usual age of menarche? 9 to 12 years. Okay, anything less than 9 years is early menarche. Okay, anything more than 14 years is late menarche. Okay, and in menopause in Indian scenario and Western scenario. Indian scenario is 47 plus or minus 5. Okay, in Western scenario it is 52 plus or minus 5. Okay, so these are the things.
Okay.
And regarding your menopause definition, yeah, anyone knows what is menopause? NCCN में दिया है.
After 1
1 year
year
of
of menstruation,
year of
stoppage of menstruation, more than 60 years of age, patient has not taken any chemotherapy or not on any tamoxifen. And if it is a patient is on chemotherapy and tamoxifen, level of FSH and estradiol should be at the postmenopausal level.
Okay. Yeah, more or less, this is the definition. So, any woman more than 60 years, cessation of menopause for 1 year, okay, without any influence of drugs or any hormonal treatment, under influence of hormonal treatment with LH, FSH, and estradiol in postmenopausal range. Okay, so this is the thing. Okay, so we have talked about, yeah. So, what is thelarchy?
Thelarchy is like development of breast ducts.
Mm-hmm. So, what is the age of thelarchy and how much difference of age is between thelarchy and menarche?
15 to 16 years is thelarchy. Age gap of 2 to 4 years.
Yeah, roughly. Okay. So, and what else? So, hormones. Okay. Estrogen. So, estrogen expression. What is the relation of OC pills and HRT?
HRT, like estrogen and progesterone, both containing HRT, if it is used for long duration, especially more than 5 years, then it is a risk factor for developing CA breast. But estrogen only pills are not a risk factor.
So, are they still continuing to be risk factors? What does the recent study say?
HRT, ma'am.
OCP.
HRT, OC pills बोल रही हूँ.
OC pills, like estrogen.
Okay, I'll give you one scenario. Okay, combined OC pills, estrogen only pills, progesterone pills.
So
Which are at more risk?
Combined is a risk factor, ma'am.
Combined is next.
And then estrogen
Yeah.
only.
Yeah. So these do not have significance in present scenario because the estrogen, what is low dose estrogen pill? What is high dose estrogen pill?
Combined dose has lowest dose of estrogen.
Yeah, how much?
0.2.
0.75.
What is the, can you tell, as far as I remember, it is low dose is 20 and high dose is 50. Okay. So, but just check it as I remember. So, as he told, combined has more chances of risk. But now no longer, because they use very low dose estrogen in pills. Okay. And what was the study that has studied about the risk factor with relation to OC pills, and what is the study that studied about risk factor with relation to hormonal replacement?
Regarding study, I am not aware.
So Williams study?
Women Health Initiative, WHI.
Yes. And have you heard about Williams and Oxford study?
No, ma'am.
Yeah, Oxford is for HRT. Okay. So Women's Health Initiative and Williams are for OCPs. Okay.
Okay.
So hormone replacement therapy, as you told, more than 5 years usage. Can you tell me relative risk? How much does it increase?
It increases chances by 25%, and relative risk is around 4 to 5.
No.
2
relative
to
risk
4.
is 2.5.
2.5. Yeah.
Okay.
Yes. Hmm.
Yeah. So how much the relative risk will increase with each year of delayed early menarche and early menopause.
So
Late menopause.
delay in every year of menarche will decrease the risk by around 20%.
No.
Like this I read in Devita, but then maybe
Not 20, I think. It's around 10.
Okay.
But just check it. This numericals, I don't remember much. But just check. Okay. So you should remember relative risks of all this. Okay. Whatever are the risk factors. So can you tell me in your patient what all risk factors you have found to tell it that it is towards malignancy?
So, like usual factors like age, advanced age,
postmenopausal lady. Yes. Second.
And after that, we can't say it early menarche. It was not early menarche, so it is not. And
then
obesity, ma'am.
Okay, that you are yet to tell. Okay. So, obesity. So what obesity, postmenopausal obesity or premenopausal?
Like early childhood obesity is a risk factor, and then postmenopausal.
Significance is more in case of postmenopausal obesity. Okay.
Yes.
So okay. Then.
And
since we have come to obesity, can you tell me what all cancers are caused by obesity?
Obesity, C endometrium, ma'am.
Okay.
CA pancreas, if I'm not wrong, and CA breast.
CA prostate.
Colon, RCC. Colon, RCC.
CA colon, yes.
RCC.
Yes.
RCC, okay.
Anything else?
Esophagus, ovary.
Esophagus, adenocarcinoma, ovary.
Ovary. Then?
Esophagus, adenocarcinoma.
Gastric is also there.
Gastric is less likely. Okay. So, what about smoking? What are the cancers caused by smoking? And what is the relative risk in breast cancer?
So, smoking, like when we can start from upper digestive to the GI part. Like I can tell in parts like oral cavity, then oropharynx, larynx, lung.
Except endometrium, I think everything.
There is a mnemonic.
Everything.
So I don't know how many while preparation we read British, no? So there was a mnemonic. Kept slaps karke. Okay.
Ma'am, except endometrium, everything.
Yeah, endometrium. It's
endometrium protective.
So caps slaps करके दिया था mnemonic. Okay, kidney. Okay, esophagus, pancreas. Okay, this stomach. Okay, liver.
Breast, ovary and prostate को छोड़ के सबसे था ना.
Breast में भी है, but prostate plus minus है. Prostate.
So there is a table in Devita, which is definitely causing smoking is definitely causing those cancers. there is a little suspicion about causing cancer, and it's against causing cancer. That table is there, no, in Devita.
Yes.
Yes.
Smoking.
No.
So,
Enough evidence to say.
उसमें क्या आता है जिसमें there is no relation proved? What is that cancer which says there is no actual direct relation? No, not prostate. Not prostate. There is ovary, there is breast, and there are other cancers.
मैम अर्ली मीनार्क वाला जो पॉइंट था ना, उसमें 20% डिक्रीज ही है. 20% डिक्रीज ऑन ईच ईयर डिले अर्ली मीनार्क.
Okay.
एंड लेट एज फुल टर्म प्रेगनेंसी में आफ्टर 30 years 2 to 5 fold.
I'll ask him. Okay, full term. What is the risk? Okay, we'll talk about pregnancy.
Yes.
So tell me. So smoking का वो ही है. Okay, ovary I think it's not there. So you tell me now. She's talking about pregnancy. What has pregnancy got to do with breast cancer?
So first, full-term pregnancy affects the risk of developing CA breast. If it is after 30 years, then the risk is more. And even after first pregnancy, if the second pregnancy is at the gap of 10 years, then...
So are you interested about first childbirth or last childbirth?
First.
Why?
Because the breast epithelial terminal development occurs at the time of first pregnancy. So if the time interval between first menarche and first pregnancy is more, there will be more chances of getting some mutations that will be proliferated more during the first pregnancy.
So it all boils down to estrogen influencing it. Okay, what is the age before which it is considered as delayed pregnancies?
More than 30 years.
And relative risk?
The relative risk is around 2 to 4.
ये सब का ना मैम लेस देन इक्वल टू 2 दिया है इसमें.
That is one table, Soumita, but in separately when they are given description, no, most of the relative risks blindly you can remember it is around 2.5. It's here and there, 2.4, 2.3 like that. But most of them will come to 2.5. Okay, in and around 2.5 in breast. But that classification is different. Like less than 2, 2 to 4, more than 4. किस में है which his history of the family history, benign breast biopsies, radiation, age of childbirth, radiation, the mutations, the rate, all these are atypical ductal hyperplasia. All this is in one table. Okay. Yes. So just if you can tell, you tell that table. So most of the times 2 to 4. More than 4 and less than 2 are accepted. Okay. So, but if they ask you in specific, most of them will be in and around 2.5. So that is the. Then, so we discussed about early menarche, late menopause. Then we discussed about previous breast biopsies. Fine. Next page. Why did you ask about irradiation?
So any history of irradiation to neck or chest especially during childhood, or I'll say more before 30 years, is associated with increased risk of developing CA breast.
What radiation you were talking about?
Say for radiation for Hodgkin's lymphoma. For
mental radiation.
What is that field called?
Mantle field radiation.
So it was all in one sub. Now no longer followed, but it is one point. Okay. So you are by asking this point now, you are more concerned about treatment strategies. Okay. Suppose there is a patient who has already received radiation. Okay. Yes. Of late or anything. So it will influence your breast conservation surgery and future radiation, this one. So that all things are more now at present. Okay, more of importance rather than mantle field radiation. Okay.
Yes.
So no history suggestive. Either you just tell of no history suggestive of distant metastasis, then
Oh.
a person, the examiner will ask you what were you thinking about. Okay, don't write both. Let them ask the leading questions.
Okay.
Or if you just want to finish it off, then tell each and everything if you are given time. Okay, most often you will not be given time for all this. Okay, it will be maximum 10-15 minutes. You have to hurry up. Okay, while talking to patient only, you have to examine. Okay, so most often. So what are the most common site of metastasis and what do you ask for that?
So most common site of metastasis is lumbar vertebrae, ma'am. So I will ask backache regarding like any complaint of backache while doing something.
So bone met.
Bone mets. Yes.
Okay. Next.
Lung mets or lung
What will
mets.
you ask for lung?
Cough with or without hemoptysis. Irritative cough or and then liver mets, ma'am.
Abdominal distension, jaundice, all these things.
Yes, yes.
Next, any brain mets. Important, no?
Yes, ma'am.
So if you are writing, you have to write everything. Okay? Otherwise, you have to remember. Okay?
Yes.
So brain mets, what you'll ask?
For brain mets, we can ask about any history of headache, seizures, or like sudden loss of consciousness in some cases, maybe.
Headache, visual disturbances, syncopal attacks. Okay, or vomitings. So these are the things. Okay. Anything else you missed? Okay, next, just go to the next page. Whenever you are telling past history, try telling no comorbid illness if they don't have any, because you need not ask for everything. Somebody asks, like if you enumerate, you might forget something, mentioning something. So they'll point out. So now they'll ask, are the connective tissue disorders not important?
Yes.
It does no. So just tell no comorbid illness. If they probe and ask, then you mention. Okay. So how does your past history influence your have impact on your present management? What are the things that you are looking for? Mainly diabetes, hypertension. Okay, because they should get controlled. Second thing, the most important is connective tissue disorders, because they will
affect the blood.
They will impact on radiation. Okay.
Yes.
So other things have to be controlled. So they are important. So just mention no comorbid illness. Okay.
Yes.
So you can just tell she gives history of receiving chemotherapy drugs, and some examiners, few I have seen, like some examiners, they will be, she gives history of receiving some drug which is red in color. So you can tell like that, because most of an adriamycin they'll give. So that is also, some examiners, old time examiners are interested to listen that. Okay. She has been treated with chemotherapy and she gives, she does mention these many cycles, and she has received these many cycles of some drug which was red in color. Okay, if she is not able to mention what the drugs are. So what surgery you are interested in?
Surgery, I like maybe any breast surgery, prior breast surgery or biopsy.
Okay.
Like you told through mention here only, ma'am, that coronidal.
Yeah, there only you can mention. Okay. Yeah. Anything else in the past history?
Anything else past?
So long-term medical ailments, surgical ailments. Okay. These are only important. Then any personal you mentioned. Okay. Fine. Personal history. No addictions or habituations you can tell. Okay.
Okay, ma'am.
So and vegetarian, no loss of appetite, loss of weight, not very significant, but in this case, post NSCT, it does matter. Okay.
Yes,
if they ask you what is the reason you asked, you can tell completion sake. Okay, in this case.
Okay.
No bowel bladder disturbances. Sleep is also important. Okay.
Yes.
So and allergies.
Allergy.
Right?
Yes. Food or drug.
Yeah. So family history. Tell me something about family history in breast cancers.
So family history is regarding important to ask because there are hereditary breast cancers. So like most.
So what do you mean by hereditary? What is familial?
So hereditary, in both familial and hereditary, there will be clustering of cases, but in hereditary, there is known genetic mutation along with inheritance, recognizable inheritance in hereditary. While in familial, it can be because of some genetic mutation about which we don't know the inheritance pattern, and it can be due to the shared food habits or some exposures as well, or lifestyle.
Environmental.
Yes.
Unnatural clustering of cases with a known mutation or unknown mutation. Okay, same. Then, okay, tell me what familial conditions are associated with CA breast
So
syndrome.
most common is BRCA associated one, hereditary breast cancer ovarian syndromes, BRCA 1 and 2.
What is BRCA?
BRCA breast cancer related. It is tumor suppressor gene.
No. What is BRCA?
Breast cancer antigen.
Breast cancer gene, yeah.
Yes, it's breast cancer antigen. So tell me what is BRCA 1, BRCA 2?
So BRCA 1.
What are the cancers?
These are tumor suppressor genes. BRCA 1 is associated with chromosome 17 and it is associated with mostly ER negative, early onset bilateral.
So 17, completely tell what is the 17. You have told 17. What else? Full
17 क्यों?
17 क्यों?
इतना ही पता है.
What is BRCA 2?
13 क्यों मैम?
13 Q, 12.2, 17 Q, 12, 13 I think. And okay, BRCA 1, what are the cancers?
So BRCA 1 is associated with medullary or basal-like, mostly TNBC, early onset, bilateral breast, hormone receptor negative, and other cancers are risk of breast cancer is around 75 to 80, risk of ovarian cancer is around 45 to 50 or 45 to 60%. Then there can be increased risk of CA pancreas and fallopian tube and male breast cancer as well.
BRCA 1, BRCA 2?
BRCA 1 male cancer risk is 1%, BRCA 2 it is around 6 to 7%.
So what are the other cancers? You told breast, then?
Breast,
BRCA 1.
ovary, pancreas, and prostate, and fallopian tube.
Anyone else?
BRCA 1, BRCA 2 ना मैम की rest also.
क्या?
BRCA 1.
BRCA 1 you tell?
This
पैंक्रियाटिक कैंसर भी रहता है ना?
pancreas so I think he had tell.
Colorectal कहाँ पे आएगा?
Colorectal में BRCA 1, BRCA 2.
हाँ colon भी था मैम.
Breast, colorectal, ovary, and prostatic. Okay, and pancreatic. These are 1. 2 is male breast cancer with all other associated.
Biliary is also there, no?
Hepatobiliary and all.
Yes.
So, okay. So BRCA 1 is good or BRCA 2 is good?
2 is good. BRCA 2 is good.
What is the instance of ovarian cancer in BRCA 2?
In BRCA 2, it is around 20 to 40.
So, instance of breast cancer?
In BRCA 1, it is around 45 to 60. And
it's more in BRCA 1 or BRCA 2?
More in BRCA 1.
There are different numericals given in different textbooks. It's around 60. Okay.
Yes.
So in BRCA2 it is 40. Okay. So
Yes.
then next, what is the other syndrome?
Ma'am, larynx is also mentioned in MD Anderson. BRCA2.
Yeah, BRCA2. Yeah.
So
BRCA2 has so many associations. BRCA1 is roughly remembered as BCOP. Okay. So breast, colorectal, ovary, prostate, pancreas.
yes.
Next.
Next is P53 associated Leaf-Romani syndrome. It is around incidence is around 1% for CA breast. And then after that PJS, STK11 and BRIP1.
So there is some classification of saying high risk genes, moderate risk genes, high penetrance, low penetrance.
Yes, ma'am.
Can you tell me those things? What are high penetrance genes? What are moderate? What are low?
High penetrance are BRCA1, 2 and STK11, ATM, and moderate are.
ATM?
Yes, ma'am.
ATM कितना होता है?
Less than 1%.
Incidence? Less than 1%.
So what are other things which
Moderate
are high penetrance?
Moderate are BRIP1 and check2, PALP2. And there are other unknown or like less known foci. They are low penetrance, high frequency.
So can you tell me one? Only one? Where does Fanconi's anemia come?
Fanconi's is moderate.
Where does check mutation come?
Check in moderate, ma'am.
So BRCA1, BRCA2, TP53, P10, okay, and these are high penetrance genes, high HT, gastric cancer ka. Okay, so
sclerosing adenosis in Schwartz mentioned no increased risk.
No increased risk.
In Schwartz.
In Devita, it is less than 2, but it has no increased risk. That's why we have to stop. That's what I told him. Okay? So, sclerosing adenosis, florid hypoplasia, these have no increased risk. Okay? So, yeah. So, what are the moderate penetrance?
Moderate, check2, BRIP and PALP2. BRIP1, PALP2.
Okay, yeah, correct. And Baki sub. Okay, so these are all in low penetrance. Okay. Yes. Then what is the that is about family history, and we'll discuss about mainly how genetic counseling and all in subsequent classes. Okay, now we'll discuss only the base part. Okay. Okay, next you can proceed. So we discussed all this, right? So
yes.
मैम BMI mentioned 31.1 अगर रहता है then it is a increased risk. Okay, इतना increased risk 2.5 fold increased risk, and they have compared this BMI मतलब किस BMI से 2.5 fold increased risk, that is 22.6 BMI से they have compared.
Yeah, so BMI is one thing that he has still not come there. He just put that page. So can you tell me something about? So other things are okay. So normal build, well nourished. Okay, so they'll ask you what is build, what is nourishment. Okay, so old examiners. So what is BMI?
BMI is a body mass index. It is calculated by height divided by weight divided by height square.
Weight in
kilogram.
By
height in meters.
Okay. So, what is normal BMI? Can you tell me the grading of this BMI and what is normal range and what is obesity? What is super obesity, morbid obesity?
Normal is, ma'am, around 18.5 to 25, 24.9.
Yeah. It differs in Indian scenario. All the points will be there, but roughly 18 to 24. Anything less than 18 is malnourished. And from 24 to 30, what is it?
24 to 30, it is like I'm
Overweight.
Overweight. It is
yes,
called overweight.
Yes, overweight.
Yeah. Then comes grade 1 obesity.
Then
Yeah.
obesity, and then severe obesity above 40.
More than 40. Okay.
Yes.
Morbid
Yes.
obesity.
Yes.
So then you see the exact points and all. Okay. Before try to read it every time so that you'll remember. Okay. So and tell me about ECOG. What is ECOG?
This is, ma'am, for general condition of patient, Eastern Cooperative Oncology Group, and it has grading like ECOG 0 if the patient is having no symptom regarding the illness, and 1 if a patient is symptomatic but he or she can perform the regular activities, and 2 is patient is able to do self care only, and in 3, patient will be confined to bed less than 50% of time of day. In 4, he or she will be more than 50% time will be confined to bed and no self care. 5 will be dead.
Okay. So see, many of examiners will not accept ECOG 0. Okay.
Okay.
So at least 1 because she's symptomatic. She received chemotherapy. Okay.
Okay.
So your patient definitely is not 0. Okay.
Ma'am,
So-
that's the point I mentioned in my fat. They asked me the same thing only.
Yeah,
ECOG
0
0.
is not accepted by many of them. Though it is technically you are correct, but it will not be accepted. It is minimum of 1. Okay, generally you remember.
Patient presented
Unless
to you, we have to write 1.
You have to write 1. Yeah, every patient. Okay, patient presented to you, it is 1. Okay, so
मैंने वो
then,
सर को बोला कि sir she is doing झाड़ू and all work by her own self. Still they said no. Patient cannot
no,
be.
definitely. Like I'm telling you, 90% mindset is that if you tell 0, they will not accept. Okay. So, what are the other performance scales? What is the other name for ECOG?
PS score.
Performance status course here है. दूसरा? कोई और?
Then there that we have grading. I forgot the name just. That we have.
No, I'm asking you about ECOG only. Zubrod का नाम सुना है?
Yes, ma'am.
Zubrod. Okay.
ECOG is also known as
Zubrod.
ZUBROD. Okay.
WHO Zubot.
And what is the other performance scores?
Other, ma'am, I'm just like not getting the name.
Yeah, anyone else? They can help. All of Kornowski. Okay. Anyone can tell roughly Kornowski like above 70 what it is, 40 to 70, below 40 what it is, what it corresponds to ECOG.
Reverse order.
100 is ECOG
First is-
0.
100 is 0. 80 is 2.
So above what this one for esophageal surgery, see this performance status is important for few cases. Okay, so mainly for
HCC.
esophagus. Okay. Yeah. So what should be the performance status for esophagus for them to be fit for surgery?
Less than equal to 2.
Hey, Kornowski puts trail. Kornowski is
70.
considered in
Less than
esophagus.
70.
70 and above.
Yes, 70 and above. It should be 70 and above. Okay, then only they can be taken up. Okay. So, any other, what is the performance status scoring for children?
Children.
Lenovsky. Okay.
Lenovsky.
Lenovsky. Karnofsky, Lenovsky. Okay.
Okay.
So, whenever you are free or feeling bored, no, to read the routine things, read these things. Okay. You never know which examiner is like, they might just stop here. Okay. So, these things are important. It should not be like we don't know at all and we are mentioning. Okay. So, ECOG ka matlab kya hai ye? Bina jane, we should not, because somebody can catch you at that level. So, examiners know what we don't know. So, that is the thing. Okay. So, yeah. So, no paler, icterus, cyanosis, clubbing. In all these things, what are you interested in? First main thing in the whatever general examination findings you have mentioned.
Paler, edema.
Are you concerned more about that or something else?
Or my if the diagnosis was not certain, my generalized lymphadenopathy, I would have.
So in breast case, even though you mention generalized lymphadenopathy, please mention supraclavicular lymph nodes. Okay? Breast case, especially breast case. Okay?
Here, ma'am, or with local examination?
You should mention both. Okay. Just because you mention in general examination, if you don't mention in local examination, they will not accept it. See, if they want to catch you, 1 point is enough here. So don't give them that chance of normal mistakes. Okay. So next.
So we have to write supraclavicular.
And very important, what you wrote is very important in presence of a female chaperone. Okay. So that is very important. For male candidates, you should always tell that. Okay. See, no need to write. You won't get time to write all this. Okay. So no need to write, but while presenting, if they ask you to present incomplete, do mention the small points which will fetch you marks. Okay. So especially male candidates, all the male candidates. Next.
So then, ma'am, examination of breast and axilla. So I examined the patient in hands by side, above head, on waist, and bending forward position, and then divided the examination into.
So tell me, what is the importance of all this? Why should you examine in all these positions?
So hands by side is normal position. We will see the symmetry and any deviation of NAC or breast per se. Then above head, we can see especially that lump located in the upper part of the breast. We can see associated dimpling, retraction, puckering with the movement.
Yes, better. So occult lesions or in below the inframammary, this one, you can see better. Okay, dimpling, puckering. Right. Next.
And on waist, we can in inspection also we can guess about fixation to the muscle pectoralis major by making the patient, if the patient makes the muscle taut and the fullness increases or there is associated changes, then we can guess there might be some fixation to the muscle pectoralis major.
1 second. Above head over, on waist, you, what are you trying to tell? Pressing the hip.
Yes.
Correct?
Yes.
So what are you doing by pressing on the hip?
So by pressing the hip, if the swelling becomes more prominent or there is associated dimpling, retraction like that, these things, ma'am. So these can be pointed out.
No. What is pressing on hip for? Anyone else?
Pectoralis muscle infiltration to rule out.
So what do you see? How do you see pectoralis muscle involvement?
In palpation, so we can see by movement across and along. But
so how does it get restricted?
So in palpation, if the tumor is infiltrating the muscle, then the movement will be decreased both across and along the muscle direction.
Perpendicular to the ma'am, muscle direction.
Perpendicular है.
Yeah,
So
yeah.
but one thing is that you have to examine in a relaxed position, then ask the patient to press on the hips. Examine again. If there is restricted mobility perpendicular to the plane of the muscle, then it is supposed to be involved. Okay. How do you examine for pectoral fascia involvement?
Pectoral fascia.
Hmm.
Pectoral fascia, ma'am, then like I'm not knowing exactly, but then after making thought, maybe the restriction is not that significant.
No.
By saying the delta pectoral group,
No, pectoral fascia. See, pectoral fascia is important, right? So you have to remove the fascia. Why do you want to remove the fascia in MRM?
For
So to include the retromemory.
मार्जिन क्योंकि पेक्टोरल फेशिया का मार्जिन सर मैम मोर देन 3 या 2 सेंटीमीटर
No.
रहेगा.
To
No, it's
involve
not related to margin.
the retromemory bursa.
Something related to anatomy. How do lymphatics run? How do lymphatics run?
Lymphatics run by two superficial and deep plexus, which are connected by
anterior
Fascia
to anterior 2/3, posterior 1/3.
in relation to fascia.
fascia. So they are enclosed between this division of fascia, ma'am.
So they run along the fascia. So unless you remove the fascia, so there is chance of lymphatic spread. So that's the reason you remove the pectoral fascia. Okay. Muscle is removed when lump is very close for margin. Bending forward.
Bending forward, like if there is a large lump or the lump is fixed to the chest wall, there will be less bending, less falling forward on bending forward.
What is chest wall?
Chest wall is ribs, intercostal muscles, and serratus anterior.
Okay. Pectoral.
Pectorals are like not included in T4A, but
So they're not part of chest wall. But does it influence your surgical management? The involvement of.
For sake of
we will
remove
bola tha na. It does. You have to, if it is close to the pectoralis muscle, you have to remove it.
Yes.
Right. So it does, but it is not included in staging person. Okay. It does influence your surgical management. Okay. So then, So what is dimpling? What is puckering? What is tethering? What is pudy orange?
So dimpling is like, ma'am, when the Cooper's ligaments are infiltrated. So because of that shortening of ligaments, there can be depressions on the affected skin.
What is difference between dimpling and tethering?
Tethering is more related to Cooper's, ma'am. Dimpling and tethering different. I don't know, ma'am.
So one is inspectory, one is palpatory finding. Which is inspectory, one is which is palpatory.
Tethering is a palpatory finding and dimpling is inspectory finding.
Correct. So dimpling is inspectory and tethering is palpatory. What is pudy orange?
Pudy orange is because of the dilated back pressure, like if there are enlarged nodes in the axilla due to the back pressure.
There is standard definition. Pudy orange, what is it?
So it is orange peel-like appearance of the skin.
What is it due to? Infiltration of?
Dermal lymphatics.
Dermal or subdermal lymphatics?
Subdermal lymphatics.
It is subdermal. Subdermal lymphatics. Okay. So, so what does all this skin changes have got to do with the breast cancer? What does it give you idea about?
Ma'am, dimpling and puckering should be considered as T4B or?
No. Let's say
ulcer, satellite nodule, and pudy orange.
What is T4B? What is T4B? Definition, by definition?
It is any ulceration, satellite lesion, or pudy orange.
So you can remember it as SHUD. Okay. So it is satellite nodules, ulceration, edema. Edema is also included. Okay. And purity orange appearance. Okay. So these are dimpling and tethering are not important for staging. Same like the pectoral, this one. But they influence the surgical management. Okay. So suppose there is dimpling tethering. So you go and remove that part of the skin which is tethered, right? So, but they don't influence they're not part of skin infiltration. Okay. So that's it. Yeah. So what was I asking? Yeah. So skin. What do you want to see like about the nipple areolar complex?
So in nipple areolar complex, first we will see and there is any nipple discharge, nipple retraction. Then we will see fissuring, ulceration on the nipple as well as on the areola, and then deviation of the NSE complex as a whole.
Okay. So now we have talked about deviation of NSE complex. So tell me, what is ptosis?
So ptosis is, ma'am, the comparative like relative position of the nipple areolar complex to the inframammary fold. So if it is
what is the grading for ptosis?
So it is grade 1 if the NSE is at the IMF, and if it is below the IMF but not the dependent part, then it is grade 2, and if it is below the IMF and also the most dependent part, then it is grade 3.
What is this grading? What is the name of the grading?
Name
R से शुरू
Renault.
होता है. हाँ, Renault.
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 Okay, Renault.
Yes.
Renault.
Yes.
Okay.